We warmly welcome you all for today's online CME on MRI prostate. The prostate MRI has become an essential tool in diagnosis, staging, and management of prostate cancer. Today's session will be providing you valuable insights into the current imaging protocols, PIRADS interpretation, reporting standards, and practical tips that can be applied in our day-to-day clinical practice. It's my pleasure to introduce our moderator, Dr. Ibrahim Abugeda, Chief Medical Officer in Burjil Cancer Institute. Dr. Ibrahim is also Clinical Director in Department of Radiation Oncology in Burjil Medical City. Thank you, Dr. Ibrahim, for accepting our invitation and supporting for our online CME. Together with Dr. Ibrahim, we have Dr. Jayesh. Dr. Jayesh is consultant radiologist with us in Burjil Medical City, and he is leading our body imaging subspecialty. Along with me, Dr. Yasir will be coordinating this online CME as a panelist. Over to you, Dr. Anu. And Dr. Anu will be our speaker for the today's session. Dr. Anu is well-known radiologist from Northwestern University. She is Associate Program Director for the Diagnostic Radiology Residency Program, and she is co-director for Abdominal Imaging and Medical Student Radiology elective. So she will be talking on the topic of MRI prostate, and she will take us to the into the details of the PIRADS and the different imaging protocols related to MRI prostate. We will encourage you all to give your questions after the presentation of Dr. Anu during the discussion time. Thank you. Over to you, Dr. Anu.
Thank you so much for the kind introduction, sir. Good evening, everyone. Thank you all for logging in. Like I know it's late in the evening for you. I'm going to quickly get started. Can you see my slides?
Yes, we can see your slides.
Okay, we'll quickly get started. I know MRI prostate is a very large, wide topic, so we kind of narrow down into like what are the nuances of MRI prostate imaging, pearls and pitfalls. We'll quickly go over them. I do not have any disclosures. I have some articles that I kind of cited for like reference, so I do not have any disclosures related to those articles. What we're going to see today is prostate anatomy. Quick overview. I'm not going to go into a lot of detail, but it's important for us for interpretation. So I'm going to go over the key points, what's important in the anatomy, MRI protocol, what's recommended by the PIRADS Association, and also what we do in our institution. Overview and practical application of PIRADS. Case review, I have like close to like 20-25 cases to show examples of different locations, different types, and how they correlate to the Gleason score and Gleason grade group. Structure reporting, and then some of the prostate tumor board highlights that I've kind of incorporated into the case review by itself. So coming to the anatomy, a quick overview. We know the prostate has zonal anatomy, and then there is the large part is like the big part is the transitional zone and the peripheral zone. You can see the peripheral zone is like the most of the prostate, and then the other second bigger part is the transitional zone. And we also have a central zone which only lies in the base of the gland and some portions of the mid gland. And then there's an anterior fibromuscular stroma. I'll come and show here. And can you see my cursor? Can you see my cursor, sir?
Yeah, we can see your cursor, Dr. Anu. Yeah.
Thank you. So this is like the anatomy, like on the MRI prostate, on the sagittal MRI, the way we see is like this red part is the anterior fibromuscular stroma. It's a very thin zone. The incidence of cancer in this small little portion is only 8%, but these are one of the frequently missed cancers. So that's why I'm trying to highlight the anatomy. The things that we want to remember is the anterior fibromuscular stroma lies predominantly in the base and the midgland, very little portion in the apex, but predominantly only in the base and the midline. If you're seeing any anterior lesions in the apex, we'll have to like start looking into the anatomy more closely if it is a transitional zone, rather than calling it as an anterior fibromuscular. The same way, the central gland is only in the base and the midgland. There is no central gland in the apex. So these are small little nuances in the anatomy that we'll have to remember. And then dividing the prostate, how we divide them into base, midgland, and the apex. Any gland of any size, they are equally divided into three portions. It's not like there is no measurements that says like 5 centimeter of base and midgland or apex. It's the individual patient's prostate. If the patient's prostate is 5 centimeter in craniocaudal dimension, they are divided into 1.3 of each zone. Whereas if the patient's prostate is 10 centimeter, it is like each gland zonal anatomy will be like the base will be like 3.3 centimeter versus 1.1 in a 5 centimeter gland. So remember that. So that's the anatomy, how you divide them into base, mid, and apex. And this kind of applies similarly to the pathologist too. So for them, like sometimes you might call it as a mid gland because we're not measuring the like marking them as a measurement wise. We kind of like roughly divide them into three portions. Sometimes you might call them as a mid gland lesion. In the pathology, they might call it as an apex lesion or a base gland lesion. So don't think that is not correlating, but if you see them, if it's like completely near close to the seminal vesicle, you know it's a base. And if they call it as a mid gland, we know we are off. But if you're closing thinking of a lesion that is like more towards the inferior portion of the mid base, and the pathology crawls as a midland, probably we are calling the same lesion when you're trying to correlate the pathology. So on the axial, this is the anatomy that we are seeing. So the way we see them is the central portion is the transitional zone, and a very little portion in the anterior part, which is like a which closely aligns with the capsule, is the anterior fibromuscular stroma. And then here you can see the transitional zone here. And this is the peripheral zone as we know. And close to the base of the gland, you will see a central portion of T2 hypointensity that is like in the posteromedial aspect of the prostate. That's the central zone. The anatomy on the axial on a T2 weighted images are important because in a peripheral zone lesion, all that we are seeing is a T2, and then we see an abnormality. We are going into the diffusion and ADC images. The importance to note is the anterior fibromuscular stroma and central gland both will appear T2 dark. Just like any peripheral zone lesion, when it is T2 dark, you consider them as tumors until proven otherwise. These are inherently T2 dark. So it's important to not miss these if they are lesions. So the clue to these, if they are abnormal, is the symmetry. So anterior fibromuscular stroma, if they have an asymmetry compare from the right to the left, or if there is a capsular distortion or bulge, those are the things that kind of give us a clue towards finding a lesion on T2. Sometimes it kind of gets missed, but when you go into the diffusion weighted images, these, if they're abnormal, they will have a restricted diffusion. Though these glands are T2 dark on inherently on the T2 weighted images, if they are normal, they do not cause restricted diffusion. So when you go into the diffusion weighted images, if you see anything abnormal in these locations, like the posteromedial aspect of this peripheral zone or the anterior part of the gland in the base in the midgland, then you come back and look at the T2, and if they have an asymmetry, that is the lesion that you want to call it on a prostate MRI. So this is about the quick overview of the anatomy. So quickly talking about like the prognosis and management, there are different things that it is spoken about in prostate, like Gleason grade group, the score on pathology. They all depend on what it makes into the clinical translation of treatment, and the management strategy is different because when we talk about the zonal location, the transitional zone tumors are clinically less aggressive compared to a peripheral zone tumors, and also the volume is a very important critical factor. Like for example, a 5 centimeter tumor is considered more critical compared to like a 0.5 centimeter tumor. So these are small little things. Each of these factors point towards the management of a patient. Quick anatomy. On the axial T2, what we talk here is like this is a differentiation of a transitional zone, which is you inherently T2 dark. Depending on whether the BPH are nodules or not, they are usually T2 dark. And then the peripheral zone is inherently T2 bright, except if it has some prostatitis or a lesion in them. What we call it as a surgical capsule is actually condensation of the prostatic tissue at the margins of the transitional zone and the peripheral zone. So there is nothing that kind of limits them. It's just the transition of the parenchymal architecture, whereas the outer one is a true capsule that we have. Why it's important is nowadays we see a lot of patients going in for TURP or whole loop treatments for BPH. So this surgical anatomy, there's no like a strict capsule that they can invade into. So they kind of like rely on how much of this is going to be removed in a BPH patient. And also sometimes you will see like not infrequently you will see BPH nodules getting extruded and lying in the peripheral zone. Those are important ones, which because it's a traditional BPH benign nodule, but when they are kind of like migrate into the peripheral zone, because there's no necessarily a strict capsule, they will look like T2 dark. They will restrict because it's a fibrous nodule, and they will announce because it's a parenchymal structure. So they will cause a confusion that's a peripheral zone um, malignant lesion. So, but the morphology and other structures will kind of give us a clue towards it. These are some examples of how like a peripheral zone lesion can appear and how the capsule can be invaded. I can just show here. Another anatomy for us to keep in mind is the neurovascular bundle and the capsular extension outside the prostate. The neurovascular bundles always lie in the 5 o'clock and 7 o'clock positions of the axial anatomy. So they're not elsewhere. Like you can see some structures that are more anterior, those are usually periprostatic venous plexuses. But the T2 dark, like dot kind of signal that you see at the 5 o'clock is the left neurovascular bundle, and then the 7 o'clock is the right neurovascular bundle. So if you're seeing a lesion that kind of extends in the from the posterolateral peripheral zone, that's has more tendency to invade these neurovascular bundles. Once there is an invasion, like in the slide that I showed before, like if it kind of extends into this peripheral zone, then you can say it is a neurovascular bundle invasion, which makes it a Peyer's 5 automatically. Even if the lesion is less than 1.5 centimeter, but it has extended and involved the neurovascular bundle, it becomes automatically a Peyer's 5 lesion. And it's important for the surgeons to know, because once it has extended beyond, they will consider more radical prostatectomy and also consider adjuvant radiotherapy after the prostatectomy, because there is already migration of malignant cells outside the capsule. Um, this is another example of how, like in on the right side, you can see there are few T2 dark dot kind of a signal. That's a neurovascular bundle which is intact. On the left side, you can see the tumor that's migrating has distorted the anatomy. So this is neurovascular bundle invasion. So that's one other thing which can upgrade the lesion into a Peyer's 5 that we should be aware of. Coming to the extra prostatic extension, there are different kind of like scoring system. There is an EUSR grade, and as part of the PIRADS in our reading template, we do have mention about these terminologies. If there is a peripheral zone lesion, we say like, is the lesion abutting the capsule? Is there an irregularity? Is there a bulge? Or whether there is thickening or extension of the extra prostatic extension, which kind of again makes it a PIRADS 5 lesion. If you're like, we do not give a score, USR score per se, but we do mention the terminologies of whether it's extending outside or not. Quickly, the Pirates, the latest version, the last version update was in 2019, which was 2.1 version. If people have not gone over it, it's I think it's about a 70-page document, but it's a very readable, like you can read it over a cup of coffee. It kind of explains all the nuances of like why we are doing certain things in a different way, why it's important, kind of like it's kind of like story that you're reading, so it's like easy to read. But if you do not have the time to read a 70-page document, I recommend reading this one. It's a radiographics update, PIRADS 2.1. It is a 6-page document which kind of gives you a table saying like how it looks on T2 for like score 1, 2, 3. Like it gives with image examples. So if you're cut short of time, you can read this article. So quickly talking about what happened with the PIRADS is the PIRADS 2.0 version. This was the PIRADS 2.0. And then what they found was like here you can see right. For the peripheral zone, what they found was like you have a PIRADS 3 lesion, then you have like an enhancements with a dynamic enhancement. You can upgrade them to 4, and then a TZ lesion the same way, but like with the diffusion, if it's a higher diffusion, you can upgrade to 4. What was found in analysis was like a lot of lesions were getting missed thinking it was a BPH nodule in the transitional zone. So they did an update with the version 2.1, where if you're thinking it's like a BPH nodule or a benign appearing nodule in a transitional zone, but the restricted diffusion is very high. Where if it is a marked restricted diffusion, or it has other features like it's like more than 1.5 centimeter, or the nodule is really extending into peripheral zone and it has aggressive features, you can upgrade them to a PIRADS 3. The reason why it's getting up PIRADS 3 and above usually gets biopsied here. So we do not even report PIRADS 1 and 2 in our impressions. We only give anything that's PIRADS 3 and above into our impression. We do mention them in the body of the report, but in our impression, we only put anything that's PIRADS 3 and 5. So if we think like we are not confident leaving it as a benign nodule and it has like very severe restricted diffusion, for example, if you put an ADC ROI, if the ADC shows like 400 values, we think it's like more than what we're expecting even for a fibrotic BPH nodule. So we upgrade them into a diffusion 4, and then we give them a PIRADS 3, so they'll get biopsied because anyway they're going to do a sextant biopsy, so they can also add this as another target, and then they can prove it as benign. If it turns out to be malignant, then it's whole different game. So this was the update that happened with the version 2.1. And talking about the ADC, we do not give ADC values into our report. The reason why the PIRADS 2.1 version document kind of gives us like a rough guideline. Anything that's less than 1,000, you kind of suspect if it's in a peripheral zone to be like a pathologic nodule. If it is in a transitional zone, usually the fibrotic nodules are in the range of 800. Sorry, 800 to 900. And if the transitional zone lesions, if they are less than 600-ish, we start suspecting it could be a pathologic nodule. So it's a rough guideline. The reason why they do not give like a stringent, like strict numbers for us to like review them is because these ADC values are variable depending on what B values we use in our scanning protocol, and also it is different depending on like whether it's a Siemens scanner, MR, like a GE or a Philips scanner. So there are they're not very different, but it's kind of variable. So that's why they don't give strict numbers. But like you can use it as a rough guideline. Whenever we have questions, we kind of like do it to like kind of increase our confidence level in calling a lesion that is diffusion 3 versus a 4 by measuring the ADC. So this is our institutional protocol, keeping in compliance with the PIRADS 2.1 version recommendation. So we do a scout and then like, sorry, I'm sorry, once again, I'm gonna put it on silent. Sorry about that. So we do these protocol. I'll give, and the next slide will show what are the images. Quickly is talking about, we do a sagittal haste image, and then we kind of like see where the gland is. Sometimes we see the like gland is like very big. We have seen glands that are like 7, 8 centimeters. So like we try to plan based on the sagittal T2, and then we do the rest of the sequences. We also give glucagon injections just to reduce the peristalsis, or bowel peristalsis during the exam. We ask the patient to have a quick bowel prep before the day of exam, or at least have a bowel movement on the day of exam before they're coming to the scanner. And when they do the sagittal T2, if the technologist feels there is a lot of rectal bowel gas, then I'll talk about the bowel gas artifact in a few minutes. But if the patient has a lot of like rectal stool, they are taken off the scanner. Once they do the first scan, they ask first sequence, they ask them to like go empty the bowel and then come back. If they say like they cannot empty, like sometimes the glucagon kind of helps us because it kind of reduces the peristalsis, which will affect cause artifact in the images. And then we do contrast injection at 3 ml per second at the start of the third measurement, because we do not do a traditional pre-contrast T1 as a separate sequence. We kind of do it as part of the dynamic protocol, dynamic contrast sequence. So the first couple of 1 or 2 images will be non-contrast, and then the subsequent images are dynamic contrast announcements. So this is a rough example. Like I just populated our hanging protocol for our MRI prostate imaging interpretations. We have other sequences, but these are the core sequences that we used. The sagittal T2 images, and then we have a coronal, and then we have a coronal stir, which is a larger field of view. It kind of goes up to the inferior margin of the kidney. We kind of pick up some bone lesions and other like nodes in the retroperitoneum up to the aortic bifurcation on this, because nodes that are going up to the radiatic bifurcation are considered regional nodes for the prostate cancers. So this coronal stir is included for that. We have a full field of view axial T2, but the core images that are used for the primary interpretation of PIRADS is this axial small field of view. It's a 3 millimeter slice thickness, very small, high resolution images of the prostate. And then we have a dynamic contrast enhancement sequence, ADC, and then the diffusion weighted images. We do three B values at 50, 800, and 1600. The Pirates document version 2.1 actually upgraded the B value requirements from 1200 to 1400 at a minimum. So a lot of institutions are going up to even 2000s. In case like there's a Pirates 2.2 version comes in and they expect them to do a higher value, they'll have at least images that are valuable for them going back in time. So it was upgraded. So you at least have to have a 1400 B value as the highest B value in your protocol. We do 1600. Since we talked about the protocol, I just want to talk about the nuances of the performance because the quality of the MR prostate examination is plays a big part in our interpretation. It can make them either completely non-diagnostic or also at least will help us kind of assess what's the quality of our examination. I'm not going to go into PIQUAL. PIQUAL is the assessment. There is five grades of PIQUAL, which is like assessment of the quality of the exam. We started including PIQUAL in part of our reporting, but not completely like systematic. Like a couple of radiologists alone report the PIQUAL, which is technically saying like, hey, the quality of the examination is only 3, which means like I have only one sequence that is like one of the important sequences, which is T2, diffusion, and contrast. Only one of them is diagnostic versus PyQual 5, which is all the sequences are diagnostic quality. So if I say like I do not see a lesion and I say this is PyQual 3, the urologist kind of like know that okay, it's already a limited exam. So if they find a lesion in a systematic biopsy, they don't take it too serious because the quality of the examination was already limited. But this topic is very broad, so I didn't want to waste time. I wanted to show more cases, so I haven't like included them. So, but there are quality assessment tools as well. So I kind of broadly divided the pitfalls into technique related, anatomy related, and interpretation related. We'll quickly go over them. So technical limited, we always see them, the hip processes related susceptibility artifact. And remember, this hip processes only affects diffusion and ADC images because diffusion is a gradient sequence and gradient sequences are very susceptible to these artifacts. So the main thing that will get affected is diffusion. You can see this big artifact which causes a loss of signal in the prostate. The right side of the prostate is like literally not seen, but you can see the T2 weighted images, the quality of the image. It's kind of like a little suboptimal, but you can still see the anatomy and pick up any lesion if it is there. They they present as signal voids and geometric distortions. So what's the solution you want to do? We can do transfer the patient to a scanner that is 1.5 Tesla. That does not eliminate the artifact, but it will reduce the artifact for sure. You can increase the bandwidth of the sequence when only for increasing the bandwidth only for diffusion. The other sequences will be fine. You can switch the phase and frequency encoding direction, and then there are new sequences of diffusion that something called muse. Those kind of like newer techniques of diffusion weighted images can eliminate these artifacts. The switching the phase and frequency encoding direction, like if let's say the patient is on 1.5 Tesla already, and you still have a lot of artifact. One thing you could try is like you can finish the entire prostate imaging, like you can finish the dynamic imaging, which is usually the last sequences that you perform, and then like you can kind of switch the phase and frequency encoding for this one and try. Um, Next is bowel gas artifact. This is another one which is very easily rectifiable and also one of the most commonly ignored artifact. I mean, not ignored, but it's like frequently ignored pointer that can improve the quality of the image. For example, you can see like this is the sagittal T2 looks pretty good, like not much of stool, normal, reasonable size, like a 3.7 centimeter prostate. But look on diffusion, you can still see the artifact. This can obscure a part of the posteromedial aspect of the peripheral zone. The reason is this gas, all that we care about is the gas at the level of the prostate. We are not worried if the patient has like a giant gas-filled sigmoid colon. That usually doesn't affect except for if there is a peristalsis that is affecting artifact. But like usually this is the only zone that you're worried about at the level of the prostate. So if there is gas in here, if there is completely stool filled, I have some examples I'll show. They do not cause, but the gas causes an artifact. So this is because of the differences in magnetic property between the air and the soft tissue. So what we can do a bowel prep like a microanemia, which is part of our protocol. Sometimes patients forget to do the prep. They come in and then they say like, when we say like we see the artifact, they say like, oh no, like I already did. Like in those cases, like you can try other systems. There are literature articles in that kind of tried rectal tube placements, suctioning out air, which is not convenient for the technologist or the patients. You can do prone positioning. Let's say if the patient has little amount of air but a lot of stool, after you finish the entire scan, you can make the patient go prone just for the diffusion weighted imaging. When the air moves to the non-dependent portion, this artifact gets reduced. We have tried that; it kind of works. Endorectal coil is another one. For a long time, like even our institution, like until like probably 8, 9 years back, we were using endorectal coil. A lot of institutions were using them, but then now it's kind of like not done so far because one is the cost because they're disposable, but like every time, and then it requires a technologist to pace, or like if the technologist refuses the fellow or the resident has to go in and place, it's like time consuming, cost, and everything. So they remove this protocol, but that's an option. If you still have them, that can help to when you're putting the probe, the endorectal coil in there, it kind of pushes the stool or gas everything up about to a more cranial position, so that can help with eliminating that artifact. And just also like endorectal coil related artifacts are also possible, but like it is a solution for this one. Face encoding direction can be changed from left to right instead of from anterior to posterior. That's something technically the technologist can do. And then there are segmented EPI readout sequences that are in the market that can be tried if you have that possibility. Just showing some examples. You can see like this patient had like not much of a stool, but he has like a big bowel gas at the level of the prostate. And you can see like T2 looks fine, no issues. But then like with the diffusion and ADC, you can see that it kind of like causes a significant artifact that a lot of the peripheral zone is not even seen. Another example, you can see there's gas here. T2 looks fine, but the gas causes a significant amount of artifact over the diffusion. Another example, this was the first image on the left that we saw. The patient had a lot of stool, not gas, but he had a lot of stool. But we were wondering like if the patient can have like motion related artifact. So we took the patient off the scanner and said like, hey, do a bowel movement and come back. And then you can see it completely emptied. The exam was like really good. So it though it takes it kind of drags out the time of the scanning, but it's worth doing that small little steps. And this is another example. Like I said, like this is the level of the prostate. This patient had a significant stool above, like, in the sigmoid colon, but like at the level of the prostate, the rectum did not have much of gas. And you can see like there was no artifact in the prostate because the bowel gas or the other things are above the level, but not at the level of the prostate. So that's more important for us to focus. Next, anatomy-related pitfalls. As I mentioned, the hypertrophic anterior fibromuscular stroma. Don't mistake that to be a lesion or don't ignore that to be not a lesion. If there is asymmetry or restricted diffusion, that's when you kind of like assess, start thinking about if there is a lesion in the anterior fibromuscular stroma. Why it's important is because all the prostate biopsies are done transrectally. This is the rectum posteriorly. So when they're trying to do a transrectal biopsy, this is hard for them to reach because the prostatic urethra is in the line of sight. So unless you call them, they're going to have a very little sampling of those anterior fibromuscular stroma compared to the posterolateral peripheral zone. So if you don't call them, if it's going to be frequently missed. So that's why it's important for us to like kind of pay attention to them. Central zone, as I mentioned, this is where it usually occurs. Any asymmetry or restricted diffusion, start thinking about it on a coronal image. This is where the base and the mid gland is where you have the central gland. Examples of prostatic venous plexuses, they're usually along the anterior and lateral margins of them. They do not cause restricted diffusion. If suppose like they look dark like this, don't mistake them to be a lesion. It's outside the capsule, and you will see there will not be any restricted diffusion. They'll have a DWI signal, but there will not be any ADC restricted diffusion. Looking at the pre-contrast sequence is very important. I kind of have the same patient in another case as a case. I'll show you. So if like usually when you have a hanging protocol, if you have like a post-contrast image, if you're ignoring like the central image here, if you're looking at the other sequences, it's very easy for us to call like this T2 hypointense signal. There is mild restricted diffusion, not so much, but there is a little mild restricted diffusion, and that is enhancement to call it as a PIRATS 4. But if you go back and look at the pre-contrast image, you can see there is a T2 bright signal. This is, and you can see on the coronal stir, we had a T2 really dark signal. This is hemorrhage. Possibly patient had a biopsy before, so they had a prostatic hemorrhage in them, and then it usually looks bright. It is not, if you put an ROI on them, you will see there is no change in the signal intensity on the pre and post contrast, but it kind of looks like it's enhancing. So make sure you look at the pre contrast when you have like if you feel like it's not correlating to the other sequence. For example, like for a lesion to be enhancing this much, I would expect it to be like really T2 dark and show like good amount of restricted diffusion, not this amount of lightness. So then if it doesn't match the sequences, then you want to look for the pre-contrast to make sure there is no hemorrhage. And for the same reason, we don't do prostate MRs in a patient who has had biopsies in the previous 6 to 8 weeks. We always check and then proceed if they don't have. But sometimes patients' hemorrhage can last more than 8 weeks, but that's apart. But like as a protocol, we do not do if they had a recent biopsy. This is another example that I wanted to mention about the anatomy related. This, if you now I've mentioned that it's an extruded BPH nodule, but if you see like it's kind of like has a restricted diffusion, like bright DWI, ADC signal, T2 dark, and it is enhancing. It, unless proven otherwise, this we would think it is a PIRATS 4 lesion and call it as malignant lesion. But looking at the morphology, patient has the other BPH nodules, but it has like a really nice, well-defined capsule that kind of like is well-defined, and no other features. Can I be 100% certain this is not malignancy? No, but definitely I've seen in my practice like at least 2 or 3 times every year, I would have seen like an extruded BPH nodule. In those cases, the way I mention them, because the rest of the prostate is like pretty clean, peripheral zone. So in those things, I kind of like call this as a P4 lesion, and then I say like, however, the morphologic features can represent an extruded or exophytic BPH nodule, in which case this will be a PIRATS 2 lesion. I put that in my impression because most of the patients, like, from the time they see a urologist, get an MRI and the biopsy and the report, it's a pretty long time. By the time period is longer and it causes an unnecessary when once we say it's a PIRATS 4 lesion, the urologist is going to say like, there's a risk of cancer, and patient lives in that anxiety for like how many ever weeks until they get the final pathology report. But if I say this is possible, it could be a BPH nodule because of the morphology, the urologist is already giving them options that it's also possible it could be benign. It kind of lowers their anxiety. Of course, the pathology is going to talk for it, but like it's important to relieve the anxiety of the patient or bring down the anxiety of the patient. Alternatively, if they don't want to do a biopsy, of course, this is all going to be correlated with the PSA density, and other prostate health index, the PHI that they kind of urologists look at. But if they say like, hey, I don't want to do a biopsy, the alternative will be like you can kind of like do a 6 month or a 1 year follow-up prostate MR. And if it is a true lesion, either it would have grown in size or shown aggressive features. If it remains the same, it's possibly a BPH nodule. This again, we saw that. Sorry, this is a repeat. So interpretation related pitfall. This is what I was mentioning, like the central zone when I said when you're looking for an asymmetry. So you can see here, it's asymmetric on the left side compared to the right side. This is asymmetric and it causes restricted diffusion. You can see like the right side doesn't have much of a DWI signal compared to the left side. This patient had a 0.16 PSA density. We called it as a lesion, and then they got a biopsy. It was a Gleason 4+4. It was a high risk prostate cancer. So this is what we don't want to miss it as calling a central gland. It's a normal central gland. Whenever you're seeing asymmetry, seeing a restricted diffusion or enhancement, asymmetric enhancement, always have the antennas up for it could be pathologic. Worst case, you're calling a lesion, possible potential lesion. Like PIRATS is always telling about what's the possibility it could be a cancer. We're not saying it is a final cancer. We are saying it's a possibility of a cancer. At least they would have biopsied and put that to rest. It's a benign lesion instead of missing it and the patient comes back with a high-grade tumor later. Another companion case, you can see there is T2 dark signal and then not much of a restricted diffusion here. And then you can see, though it is asymmetric here, but it doesn't have like much of restricted diffusion, very little enhancement. This was because of the chronic prostatitis. The morphology also speaks for it because it kind of has a linear or wedge-shaped hypointensity on the T2 and like no restricted diffusion at all. So this we frequently see in patients with chronic prostatitis. And then you can see the PSA density is less than 0.15 as well. This is another one, chronic focal prostatitis. The one before I showed, like you can see there is symmetry, but signal change. In this one, you can have an asymmetry and also a signal change. This can also happen. This can usually, we see them with granulomatous prostatitis, in which like one side of it is like thinned out, T2 dark, and then you have like some very little restricted diffusion. It'll be like diffusion pilots 3, and then it'll have like significant enhancement. But the clue to it is like asymmetric thinning. Prostate cancers never cause thinning. They, on the opposite, they cause like protrusion, extension beyond the prostatic capsule, but they do not cause thinning of the gland. So usually whenever you're seeing like asymmetric thinning of the peripheral zone, always think about two options. One, the patient could have had chronic focal prostatitis like a granulomatous process, or the patient could have had a focal therapy with the newer techniques that are coming, minimally invasive techniques like cryoablations and other focal therapies for the prostate cancers. Those are usually done only when the patient has like single lesion, no other lesions in anywhere of the prostate. They try to kind of treat with focal therapy instead of doing a prostatectomy. So those patients, when they have a focal therapy, they'll cause like the atrophy of that side of the gland because of the therapeutic response. So these are the only two times when you have asymmetric thinning of the peripheral zone. This is what I was talking about. This patient had a focal therapy. So this is a normal gland. He had a peripheral zone and they did a focal therapy and you can see complete atrophy of that side of the gland. This patient underwent HIFU, high intensity focused ultrasound therapy for the peripheral zone lesion, and then it causes capsular contraction. These are the only two times when you have focal asymmetric thinning. Anterior fibromuscular stromal lesions that I already mentioned, whenever you have some asymmetry. So you can see like this also extends into the transitional zone, but like this is asymmetric on the right side, has restricted diffusion, has enhancement. So this came back as a Gleason 4+3 lesion. You can see the PSA density was 0.17. Patient's gland was not even that big for a 71-year-old, but you can see like the PSA density was high. So this was an anterior asymmetry, restricted diffusion, enhancement, asymmetry. Think about lesions in an anterior fibromuscular stroma and a central gland. This is another example, like hemorrhagic utricle cyst. You can see like it's completely T2 dark. It looks appears to be like it's in the center, but then if you correlate on the sagittal, you can see it is not in the prostate gland, but it's in the prostatic utricle site. And these lesions usually are diffusion and ADC dark because it's hemorrhage. They're not acute hemorrhage, so they are diffusion and T2 dark. It's not like diffusion bright and ADC dark. So this is a hemorrhagic utricle cyst. Do not mistake this to be a central peripheral zone lesion. So correlation with all the sequences is very important. Another example. So this patient, you can see like the whole gland, there is no delineation of like transitional zone or a peripheral zone. The entire gland is dark. And then you can see like it is very heterogeneous. The anatomy is distorted, like it's very dysmorphic, not the capsular wise, but like internal anatomy, zonal anatomy wise, it's dysmorphic. And you can see like very ill-defined, like restricted diffusion, very heterogeneous enhancement. So this we call it as like concern for, I forgot the PSA, his PSA density was very high. So we called it could be a diffuse infiltrative tumor that came back as Gleason 5+4. Like it's a Gleason 9 high risk cancer in this patient. So don't get biased by like, hey, the whole gland looks okay or like it's dysmorphic. Look at the zonal anatomy in any type of prostate, even if there is extensive prostatitis in a patient, you will see the difference between the transitional zone and the peripheral zone. There is no way usually they kind of like get completely masked by as a single gland. Another example is this one. Like here, you can see this patient did not have a prostate MRI, but he had a pelvic MRI for some bone related lesion, and you can see there is, I cannot delineate a prostate as an anatomy because it's completely dysmorphic, it's lobulated, and it's kind of like possibly infiltrating the bladder. They did a PET eventually because this was clearly a Paret's 5 lesion. It's a infiltrative prostate cancer, and you can see like they had bone lesions, they had like lesions in the pelvic lymph nodes, and the whole gland was lighting up. Diffuse tumor with seminal vesicle infiltration and bone metastases. And when you see this kind of tumor, we do not have to recommend a prostate MRI because this is obviously a stage 4 prostate cancer. Forget about the PIRADS 5, it's a stage 4 metastatic disease. So you don't have to necessarily do a PIRADS or an MRI prostate to, because we already know it's a stage 4, unless they're doing a prostatectomy. We're not going to look for any pelvic bed eventually. So these patients usually never get prostatectomy. They go for more systemic therapies. Another one, this was a very good case. He's a 68-year-old male. His PSA was only 1.2, which is like even low, it's in the low normal of a PSA normal levels. But his prostate was 234. He came in with pelvic fullness. So he had a very large prostate. And then when we calculate the PSA density, because his volume is so big, it was only 0.005. Technically, there is no, like if you're looking at only the numbers, these are not suspicious even of a tumor, but you can see obviously it's abnormal. So it is a large dysmorphic prostate. You don't see any zonal anatomy. And on the diffusion and ADC, you can see the ones that are clearly bright are dark. These are the solid portions of the tumor. The rest of the tumor is all cystic necrosis. And then this one, the role of us as a radiologist in these kind of patients is that you kind of tell the urologist like where to go on biopsy. If they do like random biopsy, because it's such a big tumor, if you they say it has happened that sometimes when they went in blind, they went in and biopsy some of the cystic portions and it came as non-diagnostic or it came at as inflammatory cells or whatever, and it kept going miss. I have the case and later I'll show you another case which got missed that way. But our role is to tell them like which is the solid portion of the tumor that they have to target for biopsy. So this came back as Gleason 5+4 adenocarcinoma, but neuro with neuroendocrine differentiation. This is the culprit that caused the PSA to drop. The neuroendocrine differentiations usually don't have androgen receptors, so they do not produce PSA. And that's why these neuroendocrine differentiated prostate adenocarcinomas go under the radar because they do not have high PSA. Most of these not most, all of the prostate cancer screening happens through PSA screening. And if the PSA is not high, they're never getting a prostate MR. And that's why this patient went under the radar for a longer time and before it became this big. So that's something to keep in mind. We do see increasing number of neuroendocrine differentiation in these tumors. And adenocarcinomas recently, at least in our institution, I'm collecting like a case, like number of cases that have neuroendocrine. We're seeing significantly increase. The percentage of neuroendocrine differentiation varies. Like, is it 5% versus 50% or 90% tumor differentiation? But definitely they have been like de-differentiating into neuroendocrine tumors. One of the literature or the etiology that's mentioned is either they can be de novo when it's 100% neuroendocrine prostate tumor, but another reason is if the patients have had other cancers in the past and they've undergone chemotherapy, they undergo something called lineage plasticity, which kind of changes the genetic biology of the patient, and that causes de-differentiation of these primary adenocarcinomas in the organs. Quick recap of the scenarios since we talked about protocol and all these pitfalls. If you have patients, if there is no bowel prep, just look at the localized images and then do either you can ask them to have a bowel movement and come back or use other strategies. If it's just gas, have the patient prone at the end of the exam to move the gas above and then do those things. You can as I said, suctioning is not convenient, but you can do the prone imaging. Hip processes, you can do it on a 1.5 Tesla scanner or use the other techniques like increasing the bandwidth or switching the phase and frequency encoding direction. Dynamic contrast, lost to time. You can sometimes when the dynamic contrast happens, patients have some issue or they push the button and you stop the scan and go, and then you lose the dynamic contrast. You only have a post contrast. You can still kind of report them in the PIRAD saying like it's an early or contemporaneous if you can. But that does not make it diagnostic. You can still use it as a biparametric MRI, because a multiparametric and biparametric is differentiated only by use of a contrast. If the patient still refuses contrast, what can we do? We can still perform the exam, and we can say that is like final pyrite scoring is limited, or you can call or grade them like a biparametric MRI. Quick example, like not just always prostate cancers have to be picked up on a PSA screening or MRI. This is an example I wanted to show. This is like an interlude that I wanted to show. Like this was on a CT. Patient had a CT for some other examination, like abdominal pain or something. There was a enhancing lesion in the peripheral zone. We recommended an MRI. Patient did not have a PSA at that point, so this was picked up on CT, recommended. You can see a classic Pyraz 4 lesion. So CT can also prompt or detect the early cancer. I'm going to quickly go through the cases. Since we kind of discussed a lot about the cases, I'm going to like quickly go through so we can have an example of all different types. So this is an example. The way I've kind of like hung up is like the left top will be the T2 weighted image. This one was our contouring software, and usually this might not be there, but then I have like a post contrast images, dynamic contrast, diffusion in the left bottom, ADC. And for some of the examples, I have a whole mount post prostatectomy samples to show like how our anatomy on or the pathology on T2 kind of correlates. This contouring on the final pathology slide is kind of correlated to what they kind of like see the lesion, they mark it, and they overlap on the T2 based images. So this is a 61-year-old, had a high PSA of 28. You can see PSA density 0.26. So you already know there's a high suspicion for cancer. And then what we see is like a 3.5 centimeter left base peripheral zone lesion. And you can see compared to the right capsule, this one is bulging. It does not invaded outside, but you can see there's a bulge. And then like not shown in this image, it was in the base, so it was invading also the seminal vesicle. Patient did not have nodes. So on T2, this is 5. One by the bulging of the capsule and also by the size of the tumor being more than 1.5. Diffusion was like significant, severe restricted diffusion. You can see the mean is like 779. Anything less than 1,000 in a peripheral zone is suspicious. You can see this is much lower. And then post contrast, it is positive. It's early enhancement. Diffuse enhancement doesn't qualify. Only the early enhancement qualifies for calling it as a positive DCE. Overall, PIRADS was 5. The initial biopsy was of the lesion was 4.3. Radical prostatectomy, it was 4.5. Sorry, 4 plus 5. And they did show bilateral seminal vesicle invasion. You might frequently see the change in the Gleason score from a systematic biopsy to a radical prostatectomy, because in a systematic biopsy, they're doing a couple of samples, like 1 or 2 samples, but in a radical prostatectomy, they have like the whole entire lesion for the sampling. And just a quick mention about what's a Gleason score. The first score, that's like 4, means like, well, the type of cells that are more suspicious for cancer are, and they count like, let's say there are 100 cells that they are sampling. If the cells have like 50 of 4 type cells, 30 of 3 type cells, and 20 of 5 type cells, they'll only call the first most prominent, most number of cells, and followed by the second prominent. So it's like 4 plus 3 is the type. Though the patient also has 5 type cells, in their limited sample, they had only so many samples. Whereas in a radical prostatectomy, they have the entire lesion. So they had more, sorry, oops, they had more of 5 cells on the second prominence. So that's where it becomes 4 plus 5. So this is not infrequently, you will see a change in their systematic biopsy Gleason score from a radical prostatectomy score. This is an example. Patient had a PSA of 5.8. His PSA density is 0.1. The lesion is here in the right anterior part. You can see restricted diffusion. There is early enhancement of the lesion, and then it correlated to the radical prostatectomy specimen. So the lesion size is 1.9. So it was a T25, diffusion 5, and a positive. So it was overall 5. Again, like as I mentioned, like in systematic biopsy, it was 4 plus 3, but in a radical prostatectomy, it became 3 plus 4. The Gleason score is 7 in both sides, but a Gleason 4 plus 3, which is 4 type of cells are more frequent, versus on a radical is 3 is the most common. Those 7 becomes from a moderate risk to a high risk tumors, even if it's switching between 4 plus 3 to a 3 plus 4. It kind of like downgraded this tumor to be a moderate risk. Not It's not a high risk tumor. So that's a Gleason grade group versus a Gleason score. Gleason grade group is used by urologists as a scoring system to tell the patients what's the probability of a high risk tumor, which means like how much probability they have for recurrence and metastatic potential. Whereas Gleason score is used by the pathologist to tell what's the type of tumor or the stage of tumor that is on pathology. So both are different. Gleason grade group is different from Gleason score. This is another example. You can see this is an example that I wanted to show. Like, the clear thing that kind of stands out first is asymmetric thinning, right? So you have like this is a diffusion bright signal, but ADC is like 11,060. Usually we want it to be less than 1,000, but you can see like it's kind of shows a little dark signal, but when you measure an ADC value, it's more than 1,000. But you have a clear T2 dark signal, has some amount of enhancement because it's just inflammation there. So this one was called as 3 because the T2 was more starkingly prominent. DC negative, Pirates 3, and then you can see like pathology came back as benign prostatic tissue. So always remember if it's an asymmetric thinning and if the T2 is not kind of matching up with the ADC or the restricted diffusion, always because diffusion enhancement will not help because it will enhance, cancer will enhance, and also prostatitis will enhance. So if they don't match, always think about prostatitis in these patients. This is the example that we spoke about. This actually, initially, the resident read it out as like Pirates 4. Then we looked at because it wasn't correlating for the amount of enhancement to the T2 and the diffusion signal, we went back and looked at the T1, and then we downgraded it to be a 2. This patient also still had a biopsy. I forgot for whatever reason. It came back as chronic prostatitis. So it was path proven to be chronic prostatitis. We didn't even have to like because chronic prostate because of the hemorrhage. This is a case that we already went over, so I'm going to skip this. This was a nice case because it's a 60-year-old patient's PSA was 4. It was just marginally high, but his PSA density, because of the size of the gland, which is PSA, his PSA density was 0.12, just below the risk. Initial read, it was called as like no lesions, negative for tumor because the patient had like a prostate tumor, but it was called negative. But this came back for the prostate tumor board discussion because they did a sampling, random sexting test sampling, because they didn't have a target. And they said it was called as a right medial base with perineural invasion. It was a high grade, not even like 3 plus 3, it was a 4 plus 5 lesion. So they brought it back to the tumor board and asked, like, hey, like, it's highly unlikely you missed a tumor like that. Like, so it was discussed again. And then you can see retrospectively looking back, there was compared, like, if in the diffusion, if you see, compared to the left side central gland, the right side is asymmetric. Compared to the left, so you can see the ADC image. Again, here, if you see, compared to the left, it's slightly asymmetric. That's probably the clue we should have picked up. We did not, and then this was missed on the initial read. And you can see like it's clearly in the right central gland. So always make sure you're looking for the symmetry for the central gland and anterior fibromuscular stroma. This is another example. It's a very subtle T2 lesion. We were surprised, like we even called it on the initially because it did look like chronic prostatitis. Like, he had a PSA of 18, but it was very high. And his PSA density was 0.47. It was very, very high. And that's the only reason we even kind of called it, because most of the rest of the gland looked like chronic prostatitis findings. There was nothing like a discrete round nodule. This was like asymmetrically looking like, okay, maybe this we could just call it, because we were worried about the 0.47, so we call it as a P4 lesion. The diffusion was very subtle, but ADC had some kind of focal uptake, so we call this a P4. We were surprised it came back as 4 plus 3. And then he had like small little like 4 plus 4 and all other ones which were not anatomically visible on MRI, but like this came back as 4 plus 3. So always make sure like PSA density is kind of like specific when it is really high, but it is not always sensitive. Sometimes you will see like the neuroendocrine tumor or even other tumors, it will show as 0.08, but then there'll be like a very big tumor. But when it is like this high, it is always like kind of points towards the risk there is a potential lesion there. Another lesion, we'll skip this because for want of time, I'll show you some more interesting cases. We went over this one. This is the pathology of this giant neuroendocrine tumor. You can see how necrotic these lesions are. Another point that I want to mention for these tumors is if you have a suspicion, the things that will point, there are a lot of necrotic, aggressive looking prostate adenocarcinomas. The ones that you want to consider a neuroendocrine one is like when you don't have a PSA. Like the PSA is like very low, like it's like the for the size of the tumor. If it's a necrotic tumor, prostate adenocarcinoma necrotic tumor, your PSA should be like sky high, like it should be like 40, 50, whatever, like hundreds or something. But if it's a neuroendocrine tumor, for the size of the tumor, the PSA in this patient, you can see it was 1.2. So when you have a discordance of the PSA, but a very large tumor, you can raise the possibility saying like either it could be a cystic type of adenocarcinomas, like cystadenocarcinoma is a thing in a prostate, or these kind of neuroendocrine differentiation. The reason is they usually do not do sampling. In our institution now, they've made it a mandate that they all get these kind of like sampling if they have an atypical tumors. But when you say there is a neuroendocrine risk, they do these extra staining like synaptophysin, chromogranin A, the kind of staining, which kind of saves time instead of coming to the tumor board discussion, then go back and take the slides and do the staining. They will kind of do it up front so they can kind of save time for these patients. So think about like giving them in the differential. I have 3 minutes. Can I go like five minutes or so, like over? Is that okay, Dr. Moore?
Yes, yes, Dr. Anu.
Okay, sorry. Sorry. So this was another subtle lesion. Like the right side lesion was pretty obvious. You can see like there was a T2 dark signal, and then you had a restricted diffusion. The left side actually was a very, very subtle tumor. It was asymmetric. It kind of like had a contour. So they did say like, okay, let's call it as a lesion. We were surprised actually. It also wasn't, but it was a high grade prostatic intraepithelial neoplasia, but it did have cancer in them. They preemptively went and like treated that case. The reason why, even if it is subtle, but if you think it's a possibility to do in a clinical realm of things, is that if let's say like we did not call this lesion, you're only calling this lesion, no other lesions present. These patients, if they are young and the rest of the gland is completely pristine, there are potential that these patients can get treated with focal therapy like HIFU, cryoablation, and stuff. And those actually like they're expensive procedures, and then they get ablated and this whole gland goes. And then if there's another lesion that you do not call for, then eventually after on the follow up, this lesion can grow and then they come back, and then at that point they'll have to go for a prostatectomy. On the contrary, if you already call there is another lesion on the opposite side, contralateral side, they might not consider a focal therapy. They will go for other options already, either a systemic therapy, or they'll kind of motivate the patient to get a prostatectomy, or keep them on an active surveillance rather than just doing a focal therapy, which is kind of added cost and then like comes back with another tumor. So that's why like it's important like you pay attention to other ones. If you think like you're not comfortable leaving it as a benign one, at least call them for a surveillance. Um, we went over this case. Sorry. I'm gonna call. I'm go over the important ones. Um, sorry. I have like a bunch of cases. I'm gonna go over the ones that are going to be very important. Yes, this is another one. So this patient had a PSA of 8.3. His PSA density was 0.25, so it was pretty high. Looking at the peripheral zone, it had like diffuse, like you can see there's diffuse T2 signal, and then was like looking like prostatitis. But you can see there's a one anterior, it is in the transitional zone. It does not have as much charcoal kind of an appearance. I can still kind of like do a contour, but like it had like when we it restricted diffusion, which B pitch nodules can also do. But when I did the ROI, like we have 715, which is much lower than what we usually expect. So there was no other lesion that we had. So we kind of like call this as a lesion, and then this lesion came back as Gleason 4+3. The reason I want to emphasize is that these are anterior lesions, and you can see like transrectal biopsy, unless you kind of like tell them if they're going with the regular sextant like systematic biopsy, it is possible that they can just go here and then miss it. They have to target this lesion much anterior. So there are instances when it's like super anterior or in the midline, exactly in the midline anterior, where they cannot get to it unless um, going through the prostate, like or like in risk of injury for prostatic urethra. Those get done as a transperineal biopsy. So they'll have to plan to get that nodule. So always when you have these kind of like changes, when you see it looks like a BPH nodule, but then like you can put an ROI, and then this gave us an additional confidence to like let's kind of like upgrade it and like, give it to a lesion, and then came back as hopeless. And you can see the prostatectomy kind of correlated to our findings. Um, this is the same case. I'm just gonna go over the ones, the highlighted ones. Sorry. I wanted to show this case, which I mentioned before. So this patient was an 80-year-old male. He had a multicystic mass in the pelvis for 7 years. It was waxing and waning. So you can see like this was in 2018. It was still dysmorphic, didn't have a prostate contour. It was looking very cystic. They biopsied it, negative for malignancy, went past, and then came back in 2020. It was much larger, but it was looking even more cystic, negative biopsy. He only had CTs. They just picked it up on CT since the biopsy was negative. They kept following this patient only on like CT for whatever reason. It was an outside patient. So two negative biopsies, then his PSA kept going up. So they came back for our imaging at our institution, and you can see we did the MRI. We said like CT is not going to help. We did the MRI, and this time what we did was we said, hey, go focus on the solid portions of the tumor. You have normal, yeah, focus on the solid portions of the tumor. We said like majority of it is cystic. Focus only on this part, which is having the solid portion. And then they did the biopsy. It came back as prostate cystadenocarcinoma. It is a Vedian type, not a very common one, but the thing to remember is these are cystic type of tumors in the prostate, which kind of mimic other ones. Like neuroendocrine can have this kind of an appearance, but neuroendocrine is even more aggressive. They can have lymph nodes, other metastases, but these can remain indolent for a very long time before they kind of become like much more larger. There's another entity called phylloides of the prostate. Um, which can also have this kind of an appearance, which looks very benign, but like it's very giant sized tumor. Um, I'm just gonna, I can stop here if you want. And then I'll take some questions. I know like it's a lot of cases, but I'll take questions if that'll be helpful because I'm talking a lot of cases now.
Dr. Jayesh, you're there?
Yes, doctor. I'm here.
Yeah.
Yes, I think we can ask our panel for some questions. Before that, I would like to thank Dr. Anu for giving this extensive topic and doing it in 1 hour time. And it's a very thank you. And I'll also invite Dr. Ibrahim for his opinion.
Thank you, Dr.
Yes.
Jayesh, for inviting me. Thank you for the opportunity. Yeah.
Yeah, thank you so much, Dr. Anu, Dr. Amul, Dr. Yasser, and Korat's team, Dr. Jayesh, for this. So I'm a radiation oncologist. So I'm, we are part of ABR. So listening to this talk really makes our life really easier. I mean, a lot of our decisions on our day-to-day depends on proper reading of the MRI. Even now with radiotherapy, there is a lot of data on boosting the focal lesion with the FLAME trial. So, I think just Dr. Anu, you kind of covered almost all scenarios, I would say, even the very rare ones, which is amazing. I was texting Dr. Amo just to make sure if we can have, hopefully we get you in person one day to Abu Dhabi or Dubai for a meeting where you can definitely enlighten us more, maybe with workshops with our radiology teams. But just for the sake of time, because it's like 8:05, I'm pretty sure a lot of people will be, can't stay longer. We'll probably have the questions maybe emailed, and then we can definitely discuss it with you on later. As well as I think this session, I think Dr. Amur will be available, right? So
Yes, doctor. Yeah.
okay, perfect. So again, I mean, our regards to our colleagues at Northwestern, special regards to Mo Abazid. He's the chair of radiation oncology. He's my friend. Tell him Ibrahim
Nice.
says hi. So
That
and then I think I mean great session. If any of our colleagues has a very dying or urgent question, we're happy maybe to accommodate it. Just because of the
Yes,
sake of time, I don't want to keep people really late. So
sure.
if there's anyone who wants to ask, please feel free to unmute and ask this question. Or if you want, feel free to email it to Dr. Amul, Dr. Jayesh, Dr. Yasser. I'm happy to also coordinate that. And then we look forward to, this is Dr. Anu's email. She thankfully shared it as well on the chat.
Yeah, I'm happy to like go over them with anybody.
Any question from our colleague? Any explanation, clarification, even any comments for the cases which is Dr. Anno explained and show
I,
us?
I just have one quick question, just as a clinician, just for because
Mhm.
I don't want to leave this session without being asked. So, Dr. Anu, we know AI in breast and in lung and in brain, I think, is doing a good job. How's it
Mhm.
doing in prostate MRI?
We have like vendors reach out to us to have the prostate being like contour, like if you're calling the lesion, or like it'll kind of like give us a lesion that will like like something like the for the mammogram they have this, I forgot the CAD software, something that will kind of like raise it. We weren't very happy with the initial couple of things. We're still doing a trial, but we felt like there's so much of even intra-reader variability, like the same exam that if I read now, like from where like there's so many studies in literature which talks about the intra-reader variability, inter-reader variability. Prostate is something that's kind of so variable, so it takes a lot of things into account, like as I mentioned, like the PSA density, PSA volume, what is this health course index, like all that kind of increases our suspicion just instead of looking at the image by itself. So it's still in trial. We haven't implemented into our practice yet. So we want to do our own assessment first before we even like have the AI. Even if it comes into practice, I think we will have that as like an added confidence tool rather than completely replacing our reads, I think.
Agreed. And because I know Mohammed Abazid, he's the head of radiation. He works a lot with lung
Mhm.
radiomics, which is
Yeah.
with the expecting the response based on the imaging. So there's a lot of probably that can be done in prostate. So again, I think we have a big volume of prostate MRIs. I think Dr. Yas and Dr. Amul have done an incredibly good job in standardizing the protocols, at least across the units. So if we'll be happy to participate in any of these clinical trials across, to have because our patient population is quite unique. It's a very variable patient population.
Yes.
So we'll be happy to maybe be part of any of those trials through you as well as a PI, and Dr. Yasser or Dr. Amul can lead from our end.
That'll
So
be
again,
awesome.
that please, I mean, if you have any of this in mind, please keep us also in mind. We'd love to have
Absolutely.
participation.
We have our urologists are like we have a very good urology team which has a lot of NIH grant trials that they're running, but usually they are comparing the African American population versus like American or Hispanic populations. But like adding a different like data will be very valuable for us. Yeah, I'll talk to our urologists who are usually the spearheading the population because they see the patients and like we kind of like help them. We work in collaboration with all the grant projects. So I'll talk to them and also I'll involve the Radong people and then I'll get back to you. That'll be awesome if you could do that.
Dr.
Yeah,
Amol, Dr. Yasser, or yours? Yeah, go ahead. Sorry.
yeah, Doctor. No, thank you for the nice presentation. I'm Dr. Vipin. See,
Thank you.
some real life scenarios, one or two cases which we have some confusion. Like when the
Mm-hmm.
zonal anatomy is well preserved,
Mm-hmm.
it's easy to rate either we are doing a diffusion weighted or T2 weighted images. But
Okay.
most of this time, when we get the patient for scanning, like he
Mm-hmm.
has undergone antibiotic for the chronic prostatitis, is evaluated for prostatitis, then it's
Mm-hmm.
become very difficult, and he has a significant BPH. It
Mm-hmm.
becomes very difficult for the tell the zone. Like last week only, I had a case.
Mm-hmm.
It was a Tyrex 2 nodule in the central zone, but it was excluded. Like you showed a case, one nodule was excluded to the peripheral zone,
Uh-huh.
but it's not always the same when there is significant BPH, and it becomes difficult. Like the
Yeah.
nodule is in the peripheral zone or the central zone. So in
Mm-hmm.
such case scenario, what should we do? We should apply the DWI criteria or the T2 criteria for pyrates grading? Because it becomes, because I'll tell you, last that case was a follow-up case, and it was
Mhm,
going T2, rising PSA significantly, was
mhm.
being evaluated for pyrates 2 nodule.
Okay.
But I thought it's different zone. I gave pyrates 4, and it came out to be a carcinoma day before yesterday on PET with metastasis somewhere. So that scenario becomes very difficult to interpret sometime for us. That
Mhm.
where's the nodule and how should we read about these cases when the
Like,
zonal anatomy has been like played with.
yeah, that's a great case. Like we always have a confusion about those ones. So when they are the PIRAS is applied based on where the lesion is. So the final PIRAS will be based on whether the lesion, it could be a BPH nodule, but if it's in the peripheral zone, we still call it as a P4. But I give a differential saying the morphologic features are suspicious. This could be an exophytic BPH nodule, and then give it in which case this can be a PIRAS too. So I give a differential, but the final PIRAS is always depend on where the lesion is at the time of interpretation, if that makes sense. Is that, I hope it's not confusing.
Yeah, yeah. Okay, got it.
Yeah,
But the thing is, sometimes the peripheral zone is so compressed that
yeah.
it's become very difficult.
Yeah, like in those cases, like we've seen, like sometimes the BPH is like so big, like the central transitional zone is like almost 95% of the tube, like prostate, and there's only very thin slim of peripheral zone. In that, if we see how far it's from the capsule, and then say like there is very thin peripheral zone limiting evaluation, and then this lesion is close to the actual capsule, not the surgical capsule, but the true prostate capsule, and say like this could be a we look at the DWI, and if it's like really dark, then we raise a possibility and call it as like a peripheral zone lesion because it's very close to the capsule. Even if it's a very thin peripheral zone, they still, if it's a transitional zone lesion, they don't kind of abut the actual capsule of the prostate. They usually are at least a little away from them.
Okay. And any time criteria, like a patient is being treated for prostatitis, like he has peripheral zone chronic prostatitis. Now PSA is still rising. So any criteria between the two MRI, like we should wait for how much time? Any can we guide the clinician, because sometimes we get the MRI too early.
Like
So the,
usually if they get treated for like here for chronic prostatitis, they don't put them on antibiotics unless it's an acute prostatitis. They don't give them antibiotics. Or if they are on the treatment, we at least wait for 4 to 6 weeks before they do the MRI. Another thing we tell our patients like as default is like abstain from sexual intercourse for 3 days before the MRI. That's another thing that we tell the patients. That actually affects the interpretation. The patient kind of the peripheral zone usually looks like it has a lot of prostatitis kind of changes if they had sexual intercourse 3 days before. So we ask them. That is another thing in our protocol. I didn't mention it in the instructions, but instruction goes like enema, and if they had biopsy in the last 8 weeks, if they're on any treatments in the last 4 to 6 weeks, like an antibiotic or something, an acute process like an abscess or something, they're getting treated with antibiotics for the prostate, and then another is like abstain for 3 days. Those are things that we always tell them, like don't schedule within those days.
okay, all right. Thank you.
Yeah.
Anu, I have a question.
Yes.
I have two questions. One regarding the lymph nodes. Which criteria should we take? Is it based on the size, or is it in the morphology? Is it the round shaped, or is it any irregular margin? Which criteria we should take for the pelvic? Especially
On
the
the
lymph nodes.
On the prostate MR, we look for the morphology. So, like, because sometimes we see like 3 millimeter nodule, but then when we do PSMA PET, it just comes like a light bulb. So, like, the size is like variable. Sometimes the node will be like 1.5, but if we clearly see a fatty hilum, that might not be able. So, if it looks shorty, like morphology wise, it's deformed, then we definitely call it on an MRI prostate. If there are a bunch of nodes, or if they're in an atypical location, for example, if it is a sizable node, but in an internal iliac node, they're not a typical draining node. And another thing that I learned from the surgeons is that when they're doing a prostatectomy and lymph node dissection, since internal iliac nodes are not typically the draining nodes, they are not kind of remove the entire thing. When they say pelvic lymph node dissection, they remove the obturator nodes, external iliac nodes, iliac chain nodes, but not the internal iliac. So if I see any internal iliac node that looks pathologic, I do put it specifically, mention it in the report, not generally like pelvic lymph nodes. I mention them because they go and actually have to take it out. Otherwise, that will be a local site of recurrence very quickly. So morphology, when answering to your question, MRI wise, morphology 100%. If it looks abnormal, it has restricted diffusion, it shows avid enhancement, I'll call them. If it is a 3 millimeter, sometimes we don't know whether we should call, or because of the size, it looks rounded, but then PSMA is going to tell them. If it's a high risk prostate, all the patients get PSA PET right after the our MRI prostate before they go into the tumor board discussion. And a lot of patients, I actually had a case to show like how a 3 millimeter lymph node, which was like barely picked up, it was like showing as light bulb on a PSMA PET. So that's hard for us to like predict it's a MET or not, but PSMA will help us.
Okay. The second question is that sometimes we do this screening MRI prostate in elderly patients with high PSA. So what I come across is that sometimes we couldn't find any lesion in that, but still in the annual screening, still the elevated PSA is there. Is that like even the first MRI, if we couldn't find the lesion, should they go for the biopsy, or in the annual screening?
We go with in those cases, we go with the PSA density, sir. Like if the patient has a large prostate, sometimes we have like 100 cc, 130 cc prostate gland. The PSA is like can be high just because of the PPH and other factors. But if the PSA density comes as like 0.01 or 0.03, our suspicion is already low. And if I don't see a lesion, we say like no PIRADS 3 or above lesions in the prostate. They don't go for a biopsy here unless they are clinical. If we say no lesion, but their PSA density is high, and they urologists do something like called a PHI, like prostate health index. If all those kind of like are high, or if the patient has a very strong family history of prostate, they'll just go do a systematic biopsy. Only those patients get. Otherwise, if their suspicion is low just because PSA is high and we don't see something, their other clinical risk factors are low, they keep them on a surveillance. Yeah, if any other question comes up, like you can email me, so like I'll respond. If suppose like I don't recognize some of my hospital email sometimes blocks emails, like randomly they'll put it in spam. If you don't get it, just send it to Trixie, and like hers will not be blocked because she has been emailing me. If you can send it to Trixie, and like I'll probably get it.
Okay, Dr. Amul and Dr. Yasser, you guys want to conclude it? Thank you so much, Dr. Ano, again, on behalf of Burjir Holdings and the Cancer Institute, at least.
Yeah, thank you, sir. Thank you for inviting me.
Thank you, Dr. Ibrahim, for joining and supporting us for this CME.
Thank you, Dr. Ibrahim. Thank you, Dr. Anna. Thank you, Dr. Jesh, for arranging this meeting. Thank you for our colleague.
Thanking Dr. Anu in a short time for such an extensive topic, and she could manage to do it under 1 hour. It's a lot to do.
Yeah, absolutely. It is a wide topic, but she has covered very nicely.
And that's what I think, as Dr. Ibrahim said, that we should collaborate for doing some MRI prostate workshop. I think we will invite you to come here and have another session, live session.
Yeah.
Sure. Yeah, absolutely, sir.
In future, definitely we'll plan for it. Yeah.
Sure. Thank you, sir.
Thank you.
Thank you. Thank you, Dr. Anu. Thank you, Dr. Amol.
Thank you so much,
all for joining. Thank you.
Thank you.
Thank you.